But we're obviously very pleased to have Dr. Bob Gill, who's a campaigning GP who produced the film The Great NHS Heist, which, if you haven't seen, is well worth watching. And we thought in today's first iteration of these discussions, we'd start with Bob just sort of setting the scene really about the origins of the National Health Service and the impact that had, the various changes which it's gone through in the 1970s, and then into when the Tories came into power under Margaret Thatcher, the introduction of the so-called internal market, and then the impact of the Health and Social Care Act. And then we'd like to open that up to the floor to see if people have got any comments or questions that they want to put to Bob. But Bob, perhaps you could set the scene for us in relation to the National Health Service, as I've said, the origins and the various iterations that it's gone through and where we're at today.
Thank you, Chris. Yeah, so I'm a full-time working GP. I got interested in what was happening to the NHS after there was a threat of further closures to hospital service provision. And then I embarked on quite a long sort of journey of learning about what's happened to the NHS and health policy and various other aspects of the structures and the function of the NHS. And it became quite apparent quite early on what we took for granted was actually a major step in civilized human relations and structures, which was the creation of the welfare state, and the NHS was part of that welfare state. It was the post-war consensus that, we shouldn't go back to the times between the wars where working class people struggled to make ends meet, let alone access healthcare. So we had the Beveridge model, which was announced in 46 and came into effect in 48. And what we saw just on the announcement was a significant drop in the suicide rate of people who were having intractable, painful medical problems. Now, that's quite a dramatic change already, even before services got up and running. And our experience in the war taught us that if you coordinate the provision of services, you can provide more for less money. And it was an extremely efficient model. And it replaced what was before it, which was various charitable hospitals, private GP surgeries, which tended to concentrate themselves in areas of affluence. So what the NHS did was to redistribute health resource and persuaded GPs to sign up to this new program, and along with which the state took over the running of the charitable hospitals and pulled everything into the NHS. And quite quickly, it started to show dividends in terms of improvements in healthcare. The NHS wasn't just delivering surgery and medical treatments. The NHS also provided basic nutrition. So, they're providing orange juice and cod liver oil and malt extract, because they realized that the root of good health starts with good nutrition. And the other pillars of the welfare state, housing, poverty, and all the rest of it, these are inextricably linked. You cannot treat health as a separate entity. Your environment is extremely important. And as a result, other countries saw what was happening in Great Britain and decided, hang on, we'll copy this system. Countries like Spain, the Scandinavian countries, Israel, Saudi Arabia, realized if you want to improve healthcare, if you want to improve the standard of living of people, this was a great model to follow.
Yeah, and you tell us then, Bob, in terms of the impact then that it initially had, because you mentioned the interwar years, and people like Harry Leslie Smith, who was a big Jeremy Corbyn supporter, an elderly chap who unfortunately has passed away now, talked about how he remembered his sister. I think she died in agony with I think it was TB, and they weren't able to afford to pay for the treatment, and other people he used to talk about would die in agony from cancer because they couldn't afford to have any intervention from the paid for health service at the time. So, I mean, this presumably had a big impact, did it not, on in relation to infant mortality rates and indeed longevity of the population at large?
Absolutely. So, women couldn't afford maternity care. You had deliveries taking place at home. You were lucky if you got access to a midwife. You know, very few people were able to access professional care. They relied on people who just learned how to deliver babies, and it was potluck whether you had a decent outcome. A lot can go wrong in pregnancy, in the delivery and after the birth of the child. Children get stuck in the birth canal. The pregnancies don't progress. Both mother and baby are in jeopardy. And you're exactly right. We saw a drop in infant mortality and maternal mortality. Ladies are given the opportunity to have their deliveries in a clean hospital environment. So there was a huge impact in terms of survival of children and the quality of care that ladies received once the NHS was established. Even simple things. It was one of the groundbreaking studies and research done within the NHS that led to the early diagnosis and treatment of preeclampsia, which is severe high blood pressure in pregnancy. And the solution for that was to deliver the baby. And you'd save the baby and the mother's life. And later on, other treatments became available. But that groundbreaking observation and intervention being available to everybody saved a lot of lives.
Yeah. Just tell us then about, I mean, because there was a sort of a consensus, wasn't there, on the, or seemingly anyway, on the National Health Service for, and indeed the welfare state across the piece, really, for a long period of time. But just tell us about the various early changes, iterations that were brought in, because I mean, it hasn't remained static, far from it, has it? I mean, what were the significant early changes? I think there were some changes, for example, in the 1970s, I believe. Just talk us through that a little bit as well.
Yeah, so we may recall that Bevan resigned on the introduction of prescription charges. Even from the birth of the NHS, there were forces at work to try and undo what had been achieved. But they weren't gaining any popular traction because what had happened, the public realized, wow, this really is progress. This really is a leveling up of opportunity for everybody, along with the other changes of the welfare state. But it really, the sort of reversal of what we'd achieved really took off in the late 1970s. Before Thatcher came to power, they produced a document which was later made public, called, it was really the minutes of something called the Economic Restructuring Group, and that was chaired by an MP, Nicholas Ridley. And within that documentation, they had drafted a program of mass privatization of public services and public utilities. And there's a special note made about how they would achieve this when it comes to the NHS, which was hugely popular, and why wouldn't it be? And they make specific reference to proceeding by stealth, to do it by incremental change, and the outcome would be to turn the NHS into multiple profit centers. That's how they defined it in that document.
Yeah.
And subsequent documentation going up to 1988, you had some written by Oliver Letwin and John Redwood, who were both working for Rothschild's Bank at the time, the privatization unit, and they produced a document called Britain's Biggest Enterprise, which again put more meat on the bones of how they would achieve their ultimate goal, which is of replicating the American health system, which is more or less being achieved.
Yeah, no, absolutely. And of course, the people that you're mentioning there, these were prominent conservatives, weren't they? I mean, Nick Ridley, was a very kind of well-known privatizing cabinet minister, very involved in the deregulating of the transport system, amongst many other things. So there's been this sort of attempt then, I suppose, to kind of asset strip the National Health Service, and particularly in that latter period. But it wasn't just confined to the Conservatives, though, was it? Although the Conservatives probably started the rot. I mean, it was then continued, wasn't it, by by new Labour. but just talk a bit about that. That post 1979 period when Thatcher came in and those reforms started to take hold. That Nick Ridley and Oliver Leckman, etc., had been sort of planning prior to that seminal actual election in 1979, because that was really when the post-war consensus was completely smashed.
Yeah, so you've got to give it to them that they've been very clever about it. So in Thatcher's term in office, what she did was to bring in managerialism into the NHS. So they bloated the senior management, and in doing so, they separated responsibility from control. So they removed control of the service provision and how the service was designed and run from the senior doctors and nurses who, to run a hospital back in those days, you had a very relatively small board of professionals who were managing a system in which they worked. But with the introduction of Lord Sainsbury, he introduced this managerialism to supposedly deliver us market discipline and somehow miraculously deliver efficiencies. Well, we know that lie has been used time and time again. It resonates with the public. But in fact, what they achieved was the exact opposite. So you ended up having a bloated administration and management system. Then came along Ken Clarke, another Tory minister, who then set about establishing an internal market within the NHS, this phony trading, buying and selling of services. The GPs would act as the purchaser and the hospital system would be the provider, and somehow this would miraculously improve productivity. Well, it was never designed to do that. It was designed to introduce the concept of exchange of money and the private sector way of doing things, and they were very successful. And then coming more up to date, we had the change in government. You had the Blair-Brown years. On the election promise of wanting to save the NHS within 7 days, he actually ran with the internal market, introduced yet more market reforms, started to do deals with the private sector. So in the early 2000s, we had this concordat with the private sector, which Alan Milburn fronted, the Labour Health Secretary. And for the first time in NHS history, you had private provision of medical services. We had already outsourced the cleaning and the catering and the laundry. So those were low-hanging fruit and that were picked off. And they said, well, that's not really healthcare. Let's get the private sector in. They made the waiting list go sky high for Tony Blair to have a reason to say, well, we need the temporary help of the private sector to get our waiting list down. So they always have a plausible narrative, but he just grabbed the baton and ran with it. So we have private sector doing operations. We have private sector doing all the ancillary works. The other devastating blow that Labour delivered and the Tories had started was the introduction of private finance initiative, which was borrowing money from the private sector at extremely expensive rates to be saddled with debt, and that debt burden be used as a financial excuse to sell off land and to sell off NHS assets to pay the PFI debt. And I'll give you a figure which might shock our listeners, is for the NHS, our total PFI borrowing was around 11 billion. The bill is going to exceed 80 billion. And when we've paid off the 80 billion, we don't own the hospitals. So in fact, you've mortgaged us to the hilt, you've given us a great debt millstone, and you've transferred ownership. So these hospitals don't belong to the public anymore. And when the PFI deals are up, who knows what sort of contract we'll enter back into. And, Streeting is touting another PFI fiasco for the public, but not a fiasco for the private companies that will be rubbing their hands and extracting profit at every opportunity.
And Bob, what impact do you think? I mean, just going back slightly, when they introduced compulsory competitive tendering and a lot of the ancillary activities, cleaning and things like that in hospitals, In your judgment, what impact did that have on the quality of service to patients?
Yeah, so we have evidence of increasing infection rates as a result of MRSA, thanks to the outsourced cleaning. You only have to go to any hospital and look at the food that is being given to the patients. The quality of food is very, very poor. You've lost control of making sure that the staff you employ are of decent quality. So it ended up not only putting the patients in danger, poor hygiene, poor nutrition, but you ended up pushing down the incomes of those people employed to deliver by these private companies. So you have an erosion of the terms and conditions of the staff providing these ancillary services. And obviously over time, once all the other staff had been attacked, then they started to pick on the doctors and nurses using the post-financial crash 2008 austerity narrative.
Yeah, I know that my late wife, when she was in hospital, she had a very rare condition. She was in the Royal Free in London, and that's a highly reputable hospital with a great staff and so on. I'm going back about 20 odd years now, but I remember just being really shocked actually at how dirty it was. She had a lot of get well cards, and one of them dropped behind the cabinet next to her bed, and when she sort of went to pick it up, it was just filthy. And the sort of the hospital tray that goes over where you eat from, that was underneath it. There was like caked in food, it was all kind of dried food with stuck to the underside of it. And I remember looking at the lifts in the hospital, all had a film of dust, like the very fine dust that you get in a vacuum cleaner. They were coated in this dust. I mean, it was really shocking. And my mother, I'm then just sort of anecdotally talking now, Bob. I mean, she was a hospital cleaner back in the 60s, but she also, as well as doing the cleaning, they also had a sort of pastoral role in terms of talking to patients, making tea, having a chat with the patients, befriending them, and so on and so forth. Well, of course, all that. I think when CCT came in, competitive tendering, there was no time for any of that, was there? And people were, the workers, as you say, were paid a lot less, and were given very little time to do the task, and consequently standards of cleanliness dropped. And then, as you say, you got this MRSA. I mean, would you put that down to that exclusively, or would there be other factors that would have led to the that explosion? Because there was quite a lot of problems relating to that, wasn't there? I certainly seem to remember reading a lot in the media about it some years ago.
Yeah, absolutely. So, there was a study conducted by Professor Martin McKee, which showed that the escalation in MRSA cases was directly attributed to the outsourcing of cleaning. So they compared hospitals that had in-house cleaning compared to outsourced hospital services, and they could show there was this association with outsourcing. But, you raise the point about being part of a team. Cleaners, when I was training and as a junior doctor, they were part of the team. They had probably been servicing those wards for years. They knew all the staff. If there was a problem with what they were doing, the senior nurses would take it up with them there and then, because they were employees of the same hospital. So there was that element of control and quality supervision, but now that is all divorced. So you could have appalling service delivery, but there's no way for that person who's observing it to take it up. You've introduced layers upon layers of bureaucracy, and in the end, things don't happen. The other perverse thing about the PFI contracts, when not only are you indebted for the building of the hospital, but PFI contracts include all the servicing, so the cleaning and the catering and all the rest of it. So you don't have that control. And if for example, you needed a light bulb fixing, rather than the NHS hospital employed workman coming and do it at a fraction of the cost, you are forced to pay through the nose to the PFI and service provider.
Yeah.
So they, at every opportunity, they are fleecing the service and again removing money from the delivery of patient care.
Yeah. By the way, anybody who's listening in, if you want to put a question to Bob, just raise your hand and we'll bring you in. But just moving forward, though, Bob. I mean, we've had the Health and Social Care Act, which has been in the statute book now for over a decade now, hasn't it? I mean, what's been the impact of that in terms of the National Health Service and where we're at today?
Yeah, so we mentioned the creation of the internal market by Ken Clarke in the 1990s. The 2012 Health and Social Care Act made some fundamental legal changes. Remember, you didn't need legislation to keep improving the NHS. You only needed this legislation to allow them to privatize the NHS. So there was never a good justification for what they did. So they create a fake narrative to improve efficiency and all the rest of it. But in 2012, they effectively abolished the Secretary of State's duty to provide and reworded it as duty to promote. So no longer was the founding principle of the NHS that this would be publicly provided. The funding is a separate issue. The American Medicare system and Medicaid system are publicly funded through federal funding, but they're provided by the private sector. So the 2012 Act allowed us to replicate that setup, right?
Yeah.
The other thing it did, it made this artificial internal market administrative bureaucracy become a mandatory external market. So you had now no choice but to tender out all services to the private sector. So now not only was the private sector providing the ancillary services, surgical services, they were now able to provide the running of 111 services. They were now able to run GP practices. You know, one thing I forgot to tell you was the effective co-opting of the health unions, which took place in 2006 under this initiative called the Social Partnership Forum, produced by Patricia Hewitt, the then Labour Health Secretary, who then went on to bigger and better things within the private health sector with Bupa and also with the NHS running foundation trusts and health authorities. So she was there, and what that agreement effectively did was to say to Unite, Unison and the GMB, we will not fight this.
Right.
So that's why it's left down to activists like me to try and explain this gross betrayal to the public.
Yeah.
You know, if we had an effective union voice, there's no way I would have gone anywhere near documentary making.
No.
You know, it was a huge personal cost in terms of time, effort, money to do that. What were our unions doing? To this day, they are mute on what's happening to the NHS, other than calling for more funding. Well, I've explained where the funding's going.
Yeah.
And completely missing the boat in terms of how it's been repurposed away from the original model, which was effective, cost-effective, high quality, to this current model, which is really just a corporate cash cow, delivering worse quality care at greater expense. They don't explain that, and it's not particularly complicated to explain.
No, indeed. And how much of the NHS is effectively being delivered by the private sector now, even with an NHS badge at the front?
Yeah, so if you look at particular sectors, so NHS psychiatry inpatient beds, the majority of those are provided by the private sector. More than half elective joint replacement surgery is provided by the private sector. Cataract surgery, a great proportion of that is provided by the private sector. General practice, you've got the encroachment of the private sector within general practice, not only running surgeries, but also providing the IT and the patient electronic records. There are multiple siphoning points for the private sector. You know, we talked about asset stripping. What the film attempted to do was to break down the NHS, not in what we see it as a good idea to serve people in the best way for the most efficient use of resource. That's how we see it. We see it as a common good. The private sector see it as real estate, budgets, and data. These are the assets which they've gained increasing control over. And, the 2012 Act, 10 years later, was followed by the 2022 Act, which I believe is the final legislative nail in the coffin. And what that achieved was the replication of the American managed care system, which means public funding controlled by the private sector.
Yeah.
So you put all the foxes in charge of the hen coop, and more of taxpayer money will now drift into shareholder profit, chief executive bonuses. And the other perverse thing about the setup now is the way the incentives will be increasingly structured to encourage health professionals to deny care to patients.
Yeah.
That is the basis of the American system. Managed care, the less care you give them, the more money you make. And that's a quote from Nixon's health advisor going back to 1971 when the managed care model was originally proposed.
Yeah. We've got a question from somebody in the audience, but just before I go to that, Bob, I mean, what the mantra that New Labour used to always spout was is what matters is what works, and they, I'm sure, would argue that bringing in the private sector is fine because it's making the NHS more efficient, more effective, and of course, one of the things that Brown's government, the New Labour era, when they left office, they were always point to the fact that satisfaction in the National Health Service was very high. How would you respond to that, Bob?
Well, you have this strategy of privatization, which is famine and feast. No doubt under the Blair-Brown years, the money went in. But you've got to look at, did the money go in investing public service provision, public buildings, publicly run facilities? No, it didn't. It went into establishing the private sector. The private sector need a guarantee of income. So that's one thing. The private sector aren't doing it out of the goodness of their hearts. The contracts that Alan Milburn negotiated, on average, paid the private sector 20% more than the NHS for doing the same operation.
Right.
So there's money leaking out the system there. Also, the private sector is not interested in doing complex, expensive surgery. So all that expensive, complex treatment is dumped at the NHS door, whereas the easy, straightforward stuff is handed over to the private sector. And what happens when there's a complication? They're dumped back in the NHS. And we've had various scandals. There was the Serco scandal, which was providing out of hours GP services, where I believe there was multiple evidence of fraud. You had one nurse looking after the population of several 100,000 patients overnight. I put it to you, that might be very efficient in terms of generating profit, but it's not very safe.
No.
You had a private contract with a company called Vanguard for cataract surgery. Half of the patients undergoing cataract surgery had a complication, be it an infection or going blind. Now, who picked up the pieces? Who picked up the medical legal bill? Who picked up dealing with the complications? It was us and the NHS through our taxes. There is no evidence anywhere in the world that private healthcare delivers more cost-effective treatment to the patient. It just does not exist. Nowhere in the world, because the private sector will cherry pick and do the profitable stuff and are not interested in long-term chronic conditions or complexity, because there's no money there. And the way the NHS has been restructured, we've seen the closure of ITUs, we've seen the closure of A&Es being replaced by urgent care centres and a telephone line, right, which are harder to access. So, how do you get away with not providing service? Well, you substitute it with something inferior, or you hope the patient dies before they get to the hospital.
Yeah.
That's in effect what they have done.
Yeah.
So they're not delivering They're not delivering anywhere near what they could do if none of that money was being sucked out into servicing PFI debt, servicing the running of the market, which is vast, servicing the profit.
Yeah.
And I'll give you one last figure. So there were estimates done in the mid-2000s around the Patricia Hewitt era by Professor Alan Maynard of York University. He wanted to establish how much was the running of the NHS costing, how much was going out in management and administration. Now, when Thatcher took over, it was about 4%, the cheapest overhead of any system in the world. And he estimated by 2006, this had gone up to 14%. So that is 10% at that stage being sucked out of the system, not delivering one penny of care to the patient. The American system we're copying sucks out 36%. One in every $3 spent on healthcare goes out of the back door.
Yeah.
Right? In profit, in running the system. So this is an insane way of spending money unless you're at the receiving end of the profit.
Right. Okay, then, well, Bob, let's just sort of go to, we've had one question from someone in the chat. They're saying, how can I get any medical expert to confirm my conditions are due to the AstraZeneca vaccine?
Right, okay, so that is very difficult. So in terms of public discourse, the COVID inquiry, there is a determined avoidance to address the complications of the vaccine. I'm going to stick to fact here. The facts are that Pfizer's own data, so AstraZeneca, I haven't followed that closely, but there was clotting issues with AstraZeneca, and that's why it was withdrawn. But the Pfizer vaccine, even their own data, which, let's not forget, was supposed to be hidden for 75 years, they had a 1 in 800 severe adverse event rate. And that could be anything from hospitalization to death. Now, never in the history of vaccines has any vaccine been approved with that very high adverse event rate. In fact, they've pulled vaccines. There was a norovirus vaccine, which was supposedly for children to protect them against this infection. And that was withdrawn with a complication rate of 1 in 100,000. The mRNA vaccine, 1 in 800. And this was given to everybody. There's a lot more work done on this in America. They're a bit more open about discussing this. There have been Senate hearings about the complications around the vaccine. There have been gross conflicts of interest revealed, the hiding of evidence, the hiding of data, the underreporting of adverse events. Never in the history of vaccines has there been such a high reported rate of adverse events. So if you, in the American system, so if you add up every vaccine adverse event that had been reported on their VAERS data collection system, the number reported on the mRNA vaccine far exceeds everything over the last 70 years with every other vaccine. Yet this is not commonly discussed in the public domain. And unfortunately, when I've raised this matter with other doctors, even health professionals in the hospital, there is an institutional silence and deafness about this issue because people fear repercussions. Yeah. And also, unfortunately, doctors are subjected to the same sort of brainwashing as everybody else. We don't have time to look into the original research and look at the other papers. And don't forget, the dissenting views are excluded from the public discourse. They're painted as cranks or conspiracy theorists or far-right lunatics. But actually, there are, I can think of a dozen people who are internationally from different continents, from America to Australia to India to Japan, who are reporting a multitude of adverse events specifically related to mRNA and the problems with the whole platform, the whole idea about using mRNA to give you an immune protection for a virus.
Right, yeah. I think we got Chris Murphy wanted to ask a question, if he could be brought on into the chat. I'm not in control of the microphone. Can we bring Chris in to ask his question?
I've invited him to speak, but he doesn't seem to be taking it. Can I just remind all listeners, if there's anything you want to discuss around the NHS, please request to speak and we'll let you in. Or if you know anybody for next time, if you can let them know about this, that'd be great.
Hello.
I think we got Chris now. Chris, go ahead.
Yeah, it was just a question. I've heard that apparently the private hospitals they are treated with charity status when it comes to tax, and the NHS is taxed as a business. Is that true?
My understanding, I don't know the detail on it, but my understanding is there is a tax advantage to the private sector in terms of how much they are paying and what proportion they pay. You've reminded me of a related issue. You know, when the pandemic hit and hospital activity was shut down, the private sectors are on the verge of being bust. It was only the public injection of cash that saved the private sector. So we bailed out the private sector when the pandemic struck because they weren't able to do elective surgery. So they were within hours of going bust as a sector. And you know what should have happened, that was a great opportunity to bring them into the NHS and increase NHS capacity to nationalize the private hospitals rather than bailing them out.
Yeah. I mean, and just on the point about private health, I mean, a lot of the clinicians, specialists who work in the private sector are also NHS clinicians, aren't they? And I suppose while they're doing the private work, obviously they can't be doing the NHS work. I mean, is it? I mean, what we hear from the government is they're going to use the private sector to get the waiting list down. I mean. Is that a bit of smoke and mirrors going on, or is there some validity to that? I mean, and what would be a better solution, in your opinion, to than sort of saying, well, we'll just farm a lot of the people on the waiting list into the private sector?
So the reality is we have a limited pool of health professionals. So the more you divert activity to the private sector, the more you'll have NHS staff drifting over to the private sector. They're the same people. So you're, on the one hand, they're degrading service provision within the NHS and saying, oh, we can't cope with the list. And then they're outsourcing. But there's also a new scam at play whereby the private sector operates within an NHS hospital to provide, using NHS staff now with a private hat on, in the NHS facility. That is called insourcing. It's quite insane if you think about what's going on. So the NHS, the private sector is largely reliant on existing NHS staff and could not exist if the NHS didn't train up all the staff and provide them with the capacity. You know, a lot of consultants, it varies, and GPs, but some have transitioned wholly to the private sector. And to be honest, the conditions within the NHS, you can't really blame a lot of them, right? Because it's been delivered, the standards, the ethos, the working environment, the lack of resources, the starved NHS. People are thinking, I've had enough of this. I came in believing in the NHS ethos, and they drift out and say, well, at least I might have a better chance in the private sector. And I'm sure for a period of overlap, they will be treated a bit better. But once the NHS is so degraded, then they're going to screw their own staff in the private sector. That's how they work, you know. In America, where they've gone from a big proportion of primary care being provided by independent GPs, now 99% of GPs are employed by a corporation, and their terms of conditions are getting pushed right down. And if you object, they'll sack 100 or 200 doctors in a go. They don't care. If you say, I want to spend more time with my patients, you're out the door. If you object to incentive payments being paid for you to deny care to patients, you're out. So you have to become a corporate creature in order to survive in this corporatized, privatized medical system. You know, the last thing the private sector wants is a conscientious doctor who wants to go above and beyond and provide safe care and follow up when needed, because that's seen as eating into the profit. So you have more and more risk being taken with patient care. And as I said earlier, when things go wrong, they end up at the NHS again.
Yeah. As we move to the close of this discussion, then, Bob, I mean, we've spoken a lot about the problems that the National Health Service is experiencing at the moment, where it's come from, and how it's arrived where we're at. I mean, what's the solution in your opinion? I mean, a renationalisation of the National Health Service, and what would that look like in your opinion?
Yeah, I think that would be the one word for it: renationalisation. We need to stop the hemorrhaging of money out of service provision into the various PFI and all the rest of it. You cannot solve the problem of the NHS with the way the legislation is now. This sort of integrated care system, the managed care model we have, has put the private sector in charge. So if you just pour in more money, which a lot of the unions keep talking about, and NHS activists who don't quite understand and maybe inadvertently shooting us in the foot, if you are hemorrhaging money, then you don't need a transfusion of more money. You need to stop the hemorrhage. And you need to, as a priority, try and retain the experience and quality of staff that we have, because you can't blame them for wanting to leave. You know, the terms and conditions have been significantly eroded. We are now in a perverse situation where there are thousands of unemployed doctors. There was recently announced industrial action by junior doctors because there's no job for them to go to. So that's where we are. At the same time, NHS England is importing doctors from other countries. So, you know, it is dystopian, the situation we're in at the moment. So you have to retain staff, you have to recognize and reward, restore their terms and conditions, so to stop the exodus, and you have to stop the hemorrhage of funding. And the only way I can see that is to say an end to these private contracts. And another very useful thing would be to open up all these PFI contracts and look at them for potential fraud, and not to the private sector and to the PFI holders.
I mean, so when just speaking in defence of the unions, to some extent, when they're talking about more money, some of that additional money that they are requesting, maybe that could be diverted, not necessarily extra money on top of what's going in, but from what I think you're saying, Bob, they could divert some of the money which is being hemorrhaging out of the system to improve terms and conditions, because there is a problem, isn't there, in terms of like you've just mentioned, that, you know, doctors can't find a job. I'm sure I saw some statistic a while ago of about 100,000 vacancies. I don't know whether that's a correct figure or not across the piece in terms of nurses and doctors and just in general the support services for the National Health Service. My partner, she works as a support worker for a consultant in the local Derby hospital, and their numbers have been shrinking all the time. And obviously that then has a knock-on impact, it seems to me. If you're not providing the necessary ancillary admin support for the clinicians, this can lead to log jams, problems, etc. And of course, they're not paid sufficiently. So, like you say, people are leaving. So there is a case, isn't there, for increasing the terms and conditions and stopping, this continual diminution of the workforce, so to doing some of this ancillary supportive role, administrative role for the clinicians, because without that, then it makes their job more difficult, doesn't it, if you haven't got proper admin backup?
Absolutely, but we need to understand how much of this administration has been created by the privatization itself.
Indeed, yeah.
So it's a, it's a beast that it needs to continually be fed. So you have to look at all those structural changes that I talked to you about, have their own cost. So if you are going to say to the administrative staff, well, hang on, there are other roles which will help, rather than administrating for the sake of management and collecting data and billing and all the rest of it. Well, why don't we use this staff to do more clinical administration? So that's fine. That is more of a reallocation of resource, isn't it?
Yes, yeah.
There are, for example, within the hospital, more and more of the clinician's time is taken up with administration as well. You can have surgeons who, because of bad planning and various other things, are unable to operate. You have an empty operation, an operating theatre, who are unable to operate, who are getting paid, right? But because the system is now so dysfunctional and chaotic, that's money down the drain. Without the renationalisation, what will continue is you'll feed the privatization and administrative beast that we've created. You have to do things in order. Once you've renationalised and no more new contracts going out to the private sector, then you'll start to see some money that can be reinvested. But if you don't do the steps in the right order, then you're just feeding the beast.
Yes, indeed. And it's a downward sort of slippery slope, I suppose. I mean, what's their ultimate aim, do you think, Bob?
Well, the ultimate aim would include the total control of data, the gathering in of genomic data, introducing identity, digital identity, and making the NHS part of a system whereby not only they have all that data to hand, but also forms part of a network of other data from other aspects of your life, your tax status, your social media presence, every aspect of your life. The NHS will form part of that nexus of total control. We have Tony Blair's friend, Larry Ellison, whose company Oracle are becoming increasingly enmeshed in NHS data and control. You've got Palantir. The goal will be to restrict access to human qualified people. You'll have more and more of an electronic interface. You'll find it harder and harder to see a person you recognize as a doctor or a nurse. What this does, again, it's rerouting money away from human resource, staff, and directing it into the big tech companies.
Yeah.
And you will have a greater proportion of unmet need, and you'll have a system which is incentivized to cover up and conceal rather than to provide high quality service. And you see this time and time again. You only have to look at the privatized utilities, water, for example. So we are paying through the nose in our water bills for a water industry that hasn't built one new reservoir in the whole country since privatization 30 or 40 years ago, who pay their executives millions in salary and dividends. And what are they doing? They're pumping raw sewage into the river. Yeah. Now, do we want to follow that rationale for healthcare?
No, indeed.
That's the path we're on.
Yeah.
If you want our health service to be run like Thames Water, sit back and relax.
Yeah.
If you want to do something about it, get informed and be part of the solution.
So then, just perhaps in conclusion then, Bob, I mean, what can and should people do who are concerned about their National Health Service?
Well, I think you've got to get involved. You've got to become informed and involved. And I think we still have a huge problem of lack of information, lack of understanding. If you're in a union, particularly a health union, you need to challenge them in terms of what have they done in terms of informing their members and putting some money into raising awareness. Because I'm not aware of any effective effort that's been made. And in fact, my own personal experience is they don't want to know. I've been what do you call it, cancelled by Unite the Union, despite being a member of Unite the Union.
Right.
the BMA and other sort of organisations, the RCN. If you're a member of any of these professional bodies and unions, you need to ask yourself, given what you've heard today, and follow this up with your own work, but how have they managed not to lift a finger effectively to stop what's gone on? And you know what? You know, we're in very turbulent political waters, but the people who believe in the sort of principles of the welfare state, if they don't get their head round what's happened to the NHS and ask for the right solution, they're in fact assisting the demise of the NHS.
Yeah.
And there are very few leading political figures that I've heard that talk with competence on what's happened to the NHS. And one that comes to mind is Claudia Webb, the former Labour MP.
Yeah.
She gets it. I'm not convinced Corbyn and others quite get it because of the people that surround them, or maybe they haven't had time to get their head around it. But we need to not just call for more money, we need to call for a better allocation of resources and the extraction of the private profiteers.
Yes, absolutely. Well, listen, thanks for that, Bob. That's been really a useful and fascinating discussion. Hopefully people have found it useful and informative. Just before we do wrap it up, I've been asked to give a plug for a end the bin strike protest in Birmingham on Saturday. That's this Saturday, the 18th of October, at 11 a.m. outside Shabana Mahmood's office, which is at 57 Frederick Street in the Jewellery Quarter. It's Birmingham B1 1RF. That's 1 Romeo Foxtrot. Obviously, the bin strike has been ongoing for some considerable time there, and of course, refuse collection, Bob, was made a major contribution, didn't it, to public health actually back in the day. So these are really important. I mean, you could argue, going to healthcare workers, couldn't you?
Absolutely fundamental. Cleanliness, hygiene, decent housing, decent nutrition. If those are all standards and adequate, you'd have far less burden on the health service.
Absolutely. Well, these are topics, Bob, that I think we could probably come back to in our future discussions. We wanted in this first one to give you an opportunity just to sort of set the stall out and set the scene in terms of how the National Health Service was established and all the things we've spoken about this evening to get us to where we are at. But there are obviously other specific areas that we can focus in on and have a more detailed conversation about specific aspects of the National Health Service, and then hopefully promote an interactive discussion with our listeners. But for everybody who's joined us this evening, I want to thank you, obviously, and thanks, Bob, and we'll hopefully see you next time.
Thanks, Chris.